Okay, let's start our session. Okay, so this is the first question, FOP Cardiology, FOP June. And these are the options in front of you. Kindly keep your key along with you. So if you have any if you have any queries regarding solving these papers, so you can ask directly, okay? So first question is that this is a 2-year-old girl with loud systolic murmur at mid lower sternal border. So it's a loud murmur, and it's the region is the location of the murmur is lower sternal border, mid to lower sternal border. Okay, so keep the murmur side with thrill. So if it is a thrill, so definitely the grade murmur is more than 3. Blood pressure is okay, saturation is 97, that means pink disease. Femoral pulse volume equal but not delayed from right brachial pulse. So it means equal. Apex in fifth intercostal space just lateral to the nipple line. Fifth intercostal space, that means apex beat is not displaced so much, just lateral. Just lateral means thodi si, normally it should be in the midline or medial, so a little bit displaced. Auscultation means second heart sound variable with respiration. So this is the normal physiology, variability with the respiration. So what do you think, what could be the most likely cause in this child? The cause would be VSD, simply VSD. Second question is 2-year-old, 5-year-old with left upper sternal murmur. This murmur is left upper sternal murmur, upper HP, and on the left side. Loud systolic with ejection click. So again, this is loud murmur with ejection click. Click is also there. So normally upper side pe we have a murmur. The type of murmur is ejection systolic murmur, but it is associated with click sound. Saturation is 97%. Blood pressures are normal. Femoral pulses are okay, and on splitting is also normal with respiration. So what do you think? What is a murmur? Loud murmur is the important word over here. Is this a PS or it is a ASD? Hmm? Yes. How are you going to differentiate between ASD and pulmonary stenosis? Both are the pink diseases. Both are acyanotic diseases. So if the murmur is a loud murmur, especially if you see the murmur character is loud, then think about more likely this is pulmonary stenosis, isolated PS. Okay.
मैम इसके अंदर फिक्स्ड स्प्लिटिंग भी नहीं है ना, फिक्स्ड वाइड स्प्लिटिंग भी नहीं है एएसटी.
स्प्लिटिंग नॉर्मल उन्होंने लिखी हुई, स्प्लिटिंग इन सेकंड हार्ट साउंड वेरिएबल विद रेस्पिरेशन. दिस इज नॉट
फिक्स्ड नहीं है तो मैम इस वजह से एएस भी नहीं होगा ना.
They did not mention about fixed. You are right. If they did not talk about the fixed, that means it is not ASD. Very good. And second important thing is that the murmur of the ASD is not loud. Is not loud. Okay. Pulmonary flow की वजह से होता है, soft murmur होता है आपका ASD का. So that is why this is most likely isolated pulmonary stenosis. Now the third, this is a 6-month-old with systolic murmur. Soft. The word is again the 6-month child. Now the word is soft, not the loud. The grade would be around less than 3. Okay. In the again the location is left upper sternal edge. Femoral pulse volume lower but not delayed. Not what important. Femoral pulse volume is not equal. It is lower. The word see, it's not in above case. You see the volume was equal. But now they are saying the femoral pulse volume lower but not delayed from right brachial. Auscultation, in auscultation splitting is variable with the respiration. So what do you think, what could be the cause of this murmur?
Coarctation.
Coarctation, most likely, because they are telling you the difference of the volume. That is why it is most likely the murmur is the coarctation murmur. Good. Next question. This is a 6-month-old girl diagnosed with TOF. So she's already diagnosed at the 6 month, diagnosed following in the local hospital, and they planned for corrective surgery at 1 year. So plan was there to corrective surgery at 1 year. What is the indication for urgent referral to cardiology? So we have already discussed in our
5
lecture.
attack of blue spell.
Yes, very good. So if you have a frequent cyanotic spells, then you will not going to wait for the corrective surgery. You will definitely refer the child to the cardiology for further assessment. Okay. Next question. Next question is again, this is a 14-year-old had a fatigability 2-week fever duration. So the prolonged fever is there with fatigability, night sweats. She got ear pierced 1 month back. On examination, you have diastolic murmur, splenomegaly, finger clubbing, and urine analysis show microhematuria. So what is the diagnosis over here? So it's a very simple case.
Infective endocarditis.
Infective
Yes.
endocarditis.
Very good. Prolonged fever, and then you have a heart changes as well. So diastolic murmur is there. So what do you mean by diastolic murmur is due to why? Which condition causes diastolic murmur?
MS.
And MS and
AR.
AR and PR. Okay.
Yeah.
So definitely if you have vegetations are there, most likely you have AR or PR because MS occur due to the fibrotic changes, due to the fibrosis. Okay. So because of the damage to the valves that causes diastolic murmur. So diastolic murmur along with the splenomegaly, and you can see in the urine also you have hematuria. That means they have embolic phenomena is also occurring. The emboli, the vegetations also because of the emboli moving to the kidney, that also causes hematuria. That is why infective endocarditis is the right answer. Next, 4-year-old boy with aortic valvular stenosis. This is aortic valvular stenosis. Now, what is your advice to give infective endocarditis prophylaxis? So this is again pink disease, aortic valvular stenosis. So what your advice would be there?
For dental procedure.
No, we have a clear-cut guidelines. We have clear-cut guidelines related to the infective endocarditis prophylaxis. And what were that? Can you just revise it if you can recall anyone? Revise. Everyone, anyone can. First, what?
Any prosthetic valve are used.
Yes, very good. Prostatic
and,
valve is there, so no prostatic valve is there. Okay, next.
before any episode of infective endocarditis occur.
Very good. If there is a previous history of any infective endocarditis is there, then you can give it. So there is no previous history. Third, any cyanotic heart disease. Okay.
Cyanotic heart.
So any cyanotic heart disease. So there is no cyanotic heart disease. Fourth, they will tell you that, for example, if you applied any prostatic material is there, so you have to give prophylaxis for 6 months. But if it is shunting or leakage around that material, so maybe you need to give lifelong or prolong. So for acyanotic diseases, mostly acyanotic like ASDs, VSDs, AS, you do not need prophylaxis. So what you will going to go over here? Antibiotics when developed symptoms and signs of infective endocarditis. Counsel the parents that we will only give antibiotics once the symptoms or signs of infective endocarditis will establish. Okay. So we will going to tell them about long fever. So if any fever which is prolonged and there are no source associated it, kindly come to the emergency quickly. Okay. We will going to next question. This is a Bangladesh went to his country, had fever, joint pain, and was on antibiotics. So examination you have mid diastolic murmur. So already they tell you that this child is having fever and joint pain. This child is on prophylactic antibiotics, was on antibiotics. An examination, you got the diastolic murmur. So what do you think? Why this might the diastolic murmur would be?
Mitral regurgitation. MS.
Mitral regurgitation. Are you 100% agree with it? MR causes diastolic.
Fever, this is a, I think, rheumatic fever and rheumatic fever MR.
Yes, but MR is initial. If it is acute, then you will think about MR. You are right, but this child is on antibiotics. This child has a prolonged history. Okay, prolonged. Yes, very good, Suleiman. This is a chronic. This child has developed chronic rheumatic heart disease. That is why you have a diastolic murmur, which is an indication that child has developed mitral stenosis. Okay. So if anyone on the antibiotics and has a murmur, especially the diastolic murmur, think about it is chronic rheumatic heart disease. If it is a pansystolic murmur is there, then definitely you can choose MR. Okay. The stolic murmur on the second right and suprasternal. So this murmur is on the right side, suprasternal, second right side, along with the thrill. So what do you think? What could be the murmur? Second right side pe. Most likely the murmur is
Yes.
AS. AS and they can also give you about
Yes.
the radiation as well. So in aortic stenosis, we have a carotid radiation as well. The murmur radiated to the carotids as well. So that is why the second right sound, right side pe only you have a murmur of aortic stenosis. But if the murmur is on the left side, if they tell you about left side, then it could be aortic or pulmonary. So please very clear it. If this is the left side, it could be aortic because what we discussed in our lecture that we have two aortic areas, A1 and A2. So aortic 2 area is on the left side. Third left intercostal space may you have aortic, second aortic region. So that is why you have to check for the carotids, whether the murmur is radiating to the carotids or not. If it is radiating to carotid, that means clearly this is due to the aortic stenosis. Next, this is a boy, 18 months old, upper respiratory tract infection. Initially, they have upper RTI. Then they develop tachypnea, tachycardia, hepatomegaly with basal crepitation. Tachycardia is heart rate 180. So what could be the causative organism in this case? So what is the diagnosis initially? After a respiratory infection, if the child develop hepatomegaly, tachypnea, tachycardia, so most likely this is a myocarditis. So what is a myocarditis? So what are the most common organism for myocarditis? You have to remember two. The most common organism is the Coxsackie virus B.
Yes.
The Coxsackie virus B is the most common, and after Coxsackie virus, you have adenovirus. So the answer would be here is the adenovirus. This is a 3-year-old child in ER with headache. Now this child presented in ER with the headache. And the systolic blood pressure is 130. So at the age of 3 years, the 130 is high blood pressure. What to do next? So what could be your this child in ER? Okay, this is in ER. Urgent ER referral is already in ER. Routine referral to outpatient clinic. Prescribe antihypertensive. Reassure and discharge. Repeat after 1 week blood pressure measurements. यहाँ पे जो सिनेरियो है वो इट्स क्लियर सिनेरियो नहीं है, ठीक है. ये ईआर में ही बेसिकली ये ईआर रेफरल होगा, ये चाइल्ड मैनेज होगा. क्यों मैनेज होगा? Even though the child is 3 years old, normally what happened when we check the blood pressure, the children's got started crying. They have an apprehensive behavior. Okay, because of that, sometimes the blood pressures can be raised, and you may have not a normal value at if you check one first time. So if the child presented with the symptoms, especially if they tell you about any symptoms, headache, blurring of vision, something like that, then you have to take this blood pressure serious. You cannot discharge the patient. You cannot send to the outpatient clinic. You cannot even leave the child after 1 week. We're going to assess. So all these options are wrong. The important, you have to referral, urgent ER referral, even though in scenario they already write ER. So that is why, because it is a recall, you cannot 100%, this is not your exam question, but you have to manage, you have to admit this child. Before admission, you have to check, or ER referral, you have to keep the child, or you keep the child under observation in ER. Maybe you need to repeat the blood pressure or whatever, what accordingly, but you cannot leave that child at this moment, because this child is presenting with the symptom. If the child is not presenting with any symptom, that they say the child was playful before, he was healthy, he does not have any concerns, and suddenly you took the blood pressure and the required, for example, the reading are the same, that maybe you can take the child these reading later on in the second time, third time, and so you can wait for that child. But if presented with symptoms, you cannot leave it. Okay. Child 3-month-old with mild dysmorphic features with saturation 95%, with loud systolic murmur all over the precordium. So mild dysmorphic features, 3-month child, and systolic murmur all over the precordium. So most likely this is all over precordium. The word is for VSD, and the mild dysmorphic features could suggest a Down syndrome. Okay. Yes. 28 weeker patient. So this is a 28 weeks child. Patient came with the loud murmur, a difficult wean from ventilation. What is the treatment you will going to do? So which treatment you will going to do for this child? This is basically which type of murmur. In P terms, what we discussed, the PDA is common. Okay. Yes. Ductus arteriosus is common, and if you have especially a very large PDA, it will cause problems, especially the weaning from the ventilation would be a very challenging for you if it is underlying large PDA is there, because large PDA will cause a lot of blood flow to the pulmonaries. Okay. So what treatment you will give according to the NICE guideline? So NICE guidelines still prefer ibuprofen. Okay. Even though in our setups, some people are preferred to use paracetamol these days, but you can check the neonatal guidelines. Neonatal guideline, you have a patent ductus arteriosus in your recent guideline, 2022 to 2024, neonatal ones. Okay. You can check from there the patent ductus arteriosus. The first line treatment is still ibuprofen. If first attempt of the ibuprofen fails, then they give second time ibuprofen. If second time fails, then only they give paracetamol. Okay. So this is the change according to the NICE guideline. Next question. This is a 12-year-old girl, was previously healthy. So what is important is over here, she was previously healthy, no such underlying in any disease. History of hurting her left shoulder 6 weeks ago. There is a history of left shoulder hurting. Then she did ear and nose piercing 3 weeks ago. So skin something, piercing is there 3 weeks ago, which made infection to the skin. So skin infection history is there, that responded to topical antibiotics. Now she is presented with fever and systolic apical murmur. So they are going to ask about the investigation. So what investigation you will going to do? First tell me the diagnosis, and then you will going to do the investigation. So these all are the investigations. Blood culture, echocardiography, urine electrolytes, nose swab, or blood film.
Ma'am, infective endocarditis.
always think, always very, very clear for infective endocarditis that you should have underlying cardiac disease, number one thing. Or you should have a prolonged history of IV use, IV antibiotic use, maybe IV drug abusers, or if the child was admitted in hospital and he was on prolonged IV antibiotics, okay? Or if the child is having prolonged fever, okay? Prolonged fever. So these are the important things which you suspect about. She is quite healthy, okay? She was previously healthy and now she developed skin infection. And after skin infection, if you have heart involvement, joint involvement, fever, so what first thing comes in your mind?
Rheumatic heart disease.
Very good. So then you think about the rheumatic fever. Okay. So rheumatic can involve heart, can involve joint. So you have a criteria for that. Okay. So that is why this murmur, this apical murmur, this systolic apical murmur is the MR murmur. Okay. And what is the window period for this rheumatic fever? What we discussed normally 2 to 6 weeks. Okay. Same for the glomerulonephritis as well. This skin infection can cause glomerulonephritis as well. Okay. The organism is same. Group A Streptococcus beta hemolytic, not the group B Streptococcus. It's a group A Streptococcus. You should know the name for your task paper. Okay. So now tell me what you will going to do. Do you think a blood culture will going to help you out in this scenario? Do you think blood culture will going to be help out in this scenario if it is related to the rheumatic fever?
No.
No, blood culture will not going to be help you out in this. So what you will going to do? Is there any involvement of the kidney, any nephritis picture? Then you go for urea and electrolytes. No swab will not going to be help out at the age of 3 weeks. Okay. Not same the blood film. So most likely the diagnosis, the investigation would be echocardiography. And if they provide you ASO2 titer, then you can also go for ASOT titers. Okay. So if this child is presenting with cardiac involvement, so you go for the echocardiography, which is more relevant in this scenario. Okay. This is not infective endocarditis. This is most likely a rheumatic, acute rheumatic fever. Here you can say it is acute rheumatic fever because she was previously healthy. And this is the first attack. That is why you say it is acute rheumatic fever. Down syndrome has fever, splenomegaly, hematuria. So Down syndrome, fever, splenomegaly, hematuria, hepatomegaly. So what do you think? What would be the diagnosis over here?
Infective endocarditis. Infective endocarditis.
Why infective endocarditis? Because we all know that 50% of the children with Down syndrome have underlying congenital heart disease. So indirectly, they are giving you clue about the congenital heart disease. So pulmonary, these are the different options are there. Now the scenario is in below. The first is 5 month, 39 weekers, 39 weeker, 5 month child. Systolic murmur, it's 3/6 at the lower sternal pressure border. So everything, blood pressure in the right leg, left leg is okay. Heart rate and saturation is also okay. So most likely this is the left lower sternal border. So most likely this is the murmur of VSD. Now we have 34 weeks. This child born at 34 weeks, okay? Gestational age coming for 6-week follow-up. Now this child is 6 weeks of age. Ejection systolic murmur. So you heard ejection systolic murmur, which is on the upper left sternal border. The murmur grade is 3/6. Normal heart sounds. Right, left leg is okay. And saturation is 97%. So we all know that it most likely, yes. The most likely the murmur is over here is PS because the grade is 3/6. 3. So if you have a grade 3, that means it is associated with the thrill. Okay. So this is a loud murmur. 10 days preterm baby, this is again 34 weeks, long murmur. So if they tell you about long murmur, not the loud. Loud, no, it means long. Long means it is in the systolic phase and in the diastolic
तो
phase.
हेलो, एक चीज मुझे पूछनी थी, ये जो सेकंड पे बच्चा है इसमें एएसडी क्यों नहीं हो सकता? मुझे सिर्फ ये पूछना था।
मरमर, अगर भी आपको मरमर का करेक्टर लाउड देंगे ना तो आपने पीएस सजेस्ट करना। अगर आपका यही मरमर लो ग्रेड होता, 2/6 होता, तो आप उस वक्त एएसडी पे जाते। ठीक है, उसकी वो पल्मोनरी फ्लो मरमर होता है, उसकी आवाज इतनी नहीं होती, वो सिर्फ ब्लड की इंक्रीज फ्लो की वजह से प्रोड्यूस हो। जहां पे भी आपको मरमर 4-5 ज्यादा
पीएस होगा,
हम्म,
ग्रेड 3 ऑनवर्ड्स पीएस करेंगे उसको।
बिल्कुल बिल्कुल, उसको आपने लाउड मरमर को डेफिनेटली वो करना है। ठीक, इन्होंने यहाँ पे ना सिनेरियो छोटा है, आपको एग्जाम में सिनेरियो और भी बड़ा दिया जाएगा, और भी क्लूज दिए जाएंगे। पीएस का मरमर बैक पे रेडिएट करता है, एक ये क्लू भी आपके पास होगा जो कि डिफरेंशिएट करेगा अगेंस्ट एज्ड। 10 days baby है, 34 weeks long murmur. So long means it is in systolic and diastolic both phase. So if it is in both phase, that means it is a what do you mean by this? It is in both phase, systolic and diastolic. So most likely this is a murmur. Okay. So again the child is also 34 weaker. So what they tell you, this is most likely, and the site is also at the upper left sternal border. So at the upper left sternal border, long murmur, long is a keyword for the PDA. What is, yes. What is the surest sign for the heart failure? Surest sign they are asking about. So if the surest sign for heart failure over here is
Poor peripheral perfusion
poor
or
perfusion.
pedal edema.
Perfusion you can find in sepsis as well,
Hmm.
shock as well. So it is not only or a sign for heart failure.
Hepatomegaly.
Yes. Yes, Dr. Itiza, it's hepatomegaly you are saying?
Yes, ma'am. Hepatomegaly.
Yes, this is hepatomegaly. Edema could be found in, you can see, PCM children as well. Edema can be found in nephrotic syndrome as well. So that is not the surest sign for the heart failure. Okay. So hepatomegaly is more specific for the heart failure. For the diagnosis of rheumatic fever, what investigation to rule out or rule in? So that means the specific investigation, if it is positive, it will going to rule in the disease. If it is negative, it will going to rule out the disease. So it is the most important over here is the
ASOT.
titer. Okay, because what is the criteria for that? Criteria that either you have two major or you have one major with the two minor. Along with that, you should have a supporting evidence of previous history of throat infection. So either you establish the previous history of throat infection by positive culture from the throat swab or by positive ASOT titers. Okay, so that is why ASOT titer is the answer over here. Mother, now mother with chickenpox infection 14 days before delivery. 2 days old baby coming with poor feeding, peripheral pulse cannot be detected, weak femoral pulses, capillary refill time is 4, prolonged, received IV fluid, antibiotics, and undetectable oxygen saturation, temperature is 35 degrees centigrade, still mottled skin. So what to do next in this case? So what do you think, what is the most likely cause over here? Okay, if you are giving IV fluids and still IV fluids and antibiotic, they have done the, the work, you can say, management of sepsis already. Okay. And still if the child is mottled, he's not improving, the saturation is undetectable, you have weak femoral pulses, peripheral pulses, they are saying, cannot be detected at all. Peripheral pulses, weak femoral as well. So central along with the peripheral pulses. And the age is very important. It's the 2-day-old baby. It's not the 14, 15 days old. It's the 2-day-old. So what do you think in this scenario most likely? What would you
Class
accept?
liखने of great pesos मैम.
It's not transposition. At this moment, you cannot say it's the transposition. Why it is not transposition? Because this child presented with shock. And what I told you, whenever the child presented with the shock, most likely ये systemic related dependence है PDA के ऊपर. Either यहाँ पे coarctation of aorta है, hypoplastic left heart syndrome है, most likely. इन्होंने अभी brachial pulses का हमें status नहीं दिया. हमें उन्होंने कहा peripheral pulses cannot be detected. और कोई pulses का नहीं दिया, लेकिन most likely ये left heart का problem है, चाहे वो hypoplastic हो या coarctation of aorta. Whatever, चाहे right side problem हो या left side problem हो. आपने ये 2 days का बच्चा है और हमने ये पढ़ा है 48 आवर्स के अंदर आपकी डक्ट का एनाटॉमिकल क्लोजर तो लेट होता है, बट फंक्शनल क्लोजर जो है वो 24 to 48 आवर में इट हैज स्टार्टेड. So you have to start with the prostaglandin infusion initially, okay? Then only definitely you will going to add inotropic support and everything. Whatever the child may be, this child needs sodium bicarb as well, adrenaline as well. But because it's a 2-day-old, so you have to keep the things prostaglandin, duct-dependent lesions after sepsis. Next, this is the child, this is a teenager girl, complained to her teacher that when she participated in school sport activity, she had attack of palpitation and tachycardia. So please be very clear with the symptoms they are presenting with you. If they are telling you that the child presented with the syncope, that means the differentials would be different. If the child presented with palpitation, tachycardia, then you should think about different diagnosis. Most likely you will think more about arrhythmias over here. If the child presented with syncope, then you should think more about long QT. You should more think about aortic stenosis, or you can think about hypertrophic obstructed cardiomyopathies. If the child presented with syncope like, or the history, because the sudden history death can present in both. Okay, so maybe it would not going to be help you out. But if they talk about palpitations, tachycardia, think about arrhythmias, and most common arrhythmias are the SVT. Okay, so that means the child had a palpitation due to SVT. She had history of 2 similar episode in the last 6 months. Now, what is the question, please? What is the investigation that helped in detecting the underlying cause of her palpitation? They are not saying कि detecting the palpitation. If they are saying कि detect करनी है palpitations को, उस event को record करना है, that उस वक्त आपकी different investigation हो. आपको cause को देखना है कि ये इसको SVT क्यों हो रहा है. Cause में जो हमने most likely जो cause पढ़ा था वो that was WPW syndrome. They have accessory pathways that can trigger during the time of activity. So what you going to do for this? What investigation you will perform at this time?
Exercise ECG.
No exercise. They are saying
Okay.
underlying cause.
12 lead.
12 lead ECG मैम.
WPW syndrome, you can pick on normal 12 lead ECG. Exercise ECG more specific to the strain or to the ischemic like events. Otherwise, it does not help you that much. See, in last 6 months, she had just 2 episodes. So every time during exercise, she does not have any problem. So that is why you will go for 12 lead ECG. 24-hour, or you can say a patient recorder, video recorder, whatever like this. You only need that if you want to detect the palpitations or you detect the SVT. But for the cause, you just need 12 lead ECG to look for accessory pathway. Okay. So patient event recorder is only when you want to detect SVT, or you can say detect arrhythmias. Next, 3 months with failure to thrive. This, please keep this thing in mind. This child is failure to thrive. breathlessness, bilateral basal fine capitation, thrill, murmur at the left lower sternal border. Saturation is 95. So what is the diagnosis over here?
VSD.
VSD, very good. So this child is VSD presented with large failure to thrive, that most likely this is the large VSD. This is a 1 year had a viral infection and mother complained of difficulty of feeding, breathlessness, tachycardia. Liver is also 3 centimeter below costal margin with bilateral capitation and normal air entry. So what is the diagnosis? So if it is liver is there, that means most likely the heart is
Viral.
involved. Very good. So this is viral myocarditis. Child during playing rugby collapsed. Now see the important word, collapsed. Now you don't think about SVTs. Now this child collapsed. The first thing should be come into your mind is either long QT or aortic stenosis or hypertrophic obstructive cardiomyopathy. These three differences should be in your mind. So play rugby collapsed, regain his consciousness immediately. So if it is immediately he regain his consciousness, this is most likely syncope. This collapse was not due to seizures. After that, he referred to the hospital, and at the hospital, he was fully conscious, and examination was normal. So, examination, if it is normal, means there is no murmur, nothing related to the aortic stenosis or something like that. Which investigation will you perform? So इस setup के अंदर हर जगह in every setup mostly ECGs are available. Echo can be, depends. Some tertiaries have echo facilities, but not every hospital. So at this time, most likely, which I will be going to perform with normal examination, I will go with ECG because this child regain his consciousness immediately. This is not a fit, this is the syncope. So what I would like to see in the ECG, I will see for long QT syndrome. Okay. Echo, yes, we're going to do echo as well. Isn't it? But what you will going to do, ECG will be available everywhere. And there is a normal examination finding. That is why I preferred ECG. Next question. This is a 2-year-old child choking at restaurant. So this is important. This child choke at restaurant while eating biscuits. Mother shout for the help and you found the baby drowsy with the weak cough. So what you do first? Again, you have a guidelines over here. If any child presented with choking, okay, means something stuck in the throat, choke. So first thing what you have to see is that the characteristic of the cough, whether the child is forcefully coughing or not. If someone is already coughing, then encourage him for the cough. If the child is unable to cough, you can see he's having weak cough or he's getting drowsy as well. Then after 1 year, very important, after 1 year, you will go for the abdominal thrust. You will going to give 5 blows to the back and then 5 consecutive abdominal thrust. The chest thrust are only under 1 year for the infancy. Okay. So the option would be over here is 1. Why? Because the child is having weak cough and the drowsy. If the child is already coughing forcefully, then the answer would be in that case would be encourage coughing. Okay. So should be very clear about it. Encourage cough. देखो, see the option encourage cough only. Make manual removing never. Okay, you cannot do this. Next. Neonate 6-hour boy. This is, you see, this is a 6-hour boy in the postnatal ward. Initial physical examination, midwife check, saturation was 73%. So what is the diagnosis? 73 means it is a cyanotic heart disease. So among them, what could be the cyanotic heart disease which present at such an early age, 6 hours? Most likely the answer would be over here is
Transposition, ma'am.
very good. It is a transposition of the great artery. TOF, The cyanosis normally appears in the late infancy. It is not present on the first day. TGA, or it is relay, or the answer could be drug dependent right-sided obstructive lesions like tricuspid atresia, which we have discussed. Okay, so these things can present very early. Next, girl with tachycardia, narrow complex, more than 300 beats per minute. Which drug will you going to give this? So directly they are going to ask about the drug. So which drug you will going to do in this case? This is most likely
Adenosine.
Adenosine, ma'am.
adenosine. Very good. This is a 12-day-old baby girl with 2 days. This is a 12 days. Yeah. क्या हुआ? 12 days old baby girl with 2 days deterioration and lethargy, poor feeding, lymphedema. So over here, the clue is lymphedema in hands and feet with weak femoral pulsation, murmur C2/6 with normal heart sound. So it's a low grade murmur, low intensity. Capillary refill time 3, on 100% oxygen, no oxygen saturation can be recorded. So which drug to give in this child? So which drug you will going to give this child? This is a 12-day-old baby girl.
Prostaglandin.
Prostaglandin infusion. Why? What is the diagnosis over here?
Drug dependent lesion.
Drug
Possibly
dependent.
coagulation
Drug dependent.
or coagulation.
Cooptation.
Cooptation.
Coagulation.
And what
With
lymphedema
circulatory
suggesting? Lymphedema is suggesting what? Yes, lymphedema is suggesting that the child is having Turner syndrome. Okay. So Turners are more have you can say predilection towards left-sided lesions. Okay, we have already discussed. And Noonans are associated with right-sided lesions. So that is why lymphedema is indicating this girl is Turner with coarctation of aorta. Next, child with small VSD need elective tonsillectomy. The ENT doctor needs pediatric consultation about prophylactic antibiotics. So again, I told you this is acyanotic heart disease. This is a small VSD. So what you will going to give advice related to the prophylaxis?
No need for prophylactic antibiotics.
No need for prophylactic antibiotics. Female baby 6 week, non-dysmorphic, presented with lethargy, poor feeding. During examination, you find lymphedema on the lower limbs with systolic murmur. So again, lymphedema with systolic murmur. Most likely, this is a Turner with the coarctation of aorta. Child 3 months with mild dysmorphic features. So we have already discussed this scenario. This is most likely VSD because all over the precordium, the murmur is radiating. Now, 7-year has infrequent SVT attack. The word is over here is infrequent SVT attacks. So now we will going to talk about the SVT guidelines. You have to read the SVT guidelines from your pediatric guideline book. Please write it down. You have to check it by yourself as well. Okay. So this is a 7-year-old child, infrequent SVT attack. Mother is worried if he has attack outside. So they are going to ask the management outside the hospital. So what advice you will going to give her? So you will going to advise for the Valsalva maneuver. This child is older. So you say either you have to inflate a new balloon or you can blow into the new syringe, okay? So either blow air into the syringe or inflate new balloon. Both these maneuvers will going to activate a vagus nerve, and when the vagus nerve will going to activate, it will slow down the conduction around the AV node. So this is you will advise for this outside the hospital. Immerse face in ice water is only for the neonates, okay? You will not going to do for the older childrens. Okay. So again, the
आइस वाटर की क्या है वो किसमें करते हैं यूनिट्स में
yes,
अच्छा।
neonates और infants के अंदर जो wiggle maneuver नहीं कर सकते, ठीक है? Next. 4 or 6 months with ejection systolic murmur at the left upper sternal edge. So this is 4 to 6 months with ejection systolic murmur at the left upper sternal edge. So at the left upper sternal edge, we have so many murmurs. You do not have such a small scenario in your exam. Please don't be confused with these records. They are insufficient with knowledge. Okay. So ejection systolic murmur, if it is loud, go for the pulmonary stenosis. If it is not loud, then you can think about the ASD as well. If they have give you other knowledge as well regarding the fixed, second heart sound and blah, blah. 34 weeks at 10 days with long systolic. So I've already told you if the word long is there, preterm is there, then most likely this is PDA. Patient with loud systolic at the left lower. So left lower, loud systolic, this is VSD. Boy collapsed after swimming. So we have already discussed the long QTs are associated with exercise. Specific exercise which will prone them more is a swimming. So swimming is the one which is highly prone for developing, for triggering long QT into the torsidae pointes. Okay. So especially if they talk about the swimming, think about long QT. Okay. So baby collapsed after swimming, slowly recovered his consciousness, his cousins with epilepsy. So what to do? What to do? So first thing over here is the long QT. Okay. His cousin with the epilepsy. Yes. But the thing over here is the baby collapsed why after swimming. So if you have a collapse, especially after any activity that is more towards long QT, so you will first go for the ECG. अब इधर उन्होंने लिखा हुआ है slow recovered his consciousness. This is something confusing for everyone because slow recovering is a part of fits. But in case of syncope, you normally recover quickly. Okay, so that is why it's something. Sometimes some people confused over here. They prefer EEG, but the fits are not associated with swimmings or you can say activities. So that is why I prefer to go over here in this scenario is the ECG, especially to look for the long QT. Next, 9-month-old baby with the birth weight 3.7. 3.7 means failure to thrive, basal crepitation and distress. So see this child, what do you think? What option you will going to mark over here? This child presented with failure to thrive, basal crepitation with distress. So the knowledge is insufficient over here, but what do you think? Is it a myocarditis or the VSD?
VSD.
Very good. So the failure to thrive child means this is a large VSD. If it is a myocarditis, normally the child would be healthy because that is an acute event. So that is why you do not have a history of failure to thrive in case of myocarditis. But both will cause crepitation and distress. Okay. So I'm just finishing with this one. Then we have an Amas break. Okay. This is a 7-year-old girl with SVT. The first step is always the Valsalva maneuvers. Okay, if the child is stable, then the first step would be the Valsalva maneuver. Child with the ejection systolic murmur at the right radiating to the neck is the aortic stenosis. Now again, this is a 1-month baby. This is a 1-month baby, 2/3/6 systolic left lower sternal margin पे. So अब lower sternal margin की they are talking about. This is most likely VSD. Neonate on the discharge. ओके हम यहाँ पे नमाज ब्रेक करते हैं और फिर इसके बाद हम इसको रिज्यूम करते हैं एंड देन टास्क के क्वेश्चंस वी विल गोइंग टू कवर सो जस्ट वी विल मीटिंग इन 10 मिनट्स इंशाल्लाह ओके So we left with this second question. Neonate on discharge with ejection systolic murmur on the left upper sternal with thrill. So the word over here is the thrill. That means this is the loud murmur. So this is isolated PS. Okay. Neonate on the 10-day long systolic murmur. So again, the long word is suggesting the PDA. Baby collapsed, boy collapsed during hockey game, then slowly regained consciousness. Again, the same thing. During activity, if someone is collapsed, first think about the heart-related problems. Either we have already tell you the differentials, aortic stenosis, HOCM, or long QT. Scenario, baby cyanosis with no murmur when he pull his leg up. So if the baby is pull his leg up, that means, and the cyanosis is also there. So the child is basically trying to put himself in a squatting position. Okay. He is pulling his leg towards the abdomen to increase the systemic resistance. And we already discussed during the cyanotic spell, the murmur vanish. Why murmur vanish? Because there is no flow around the pulmonary valve. So if there is no flow, then there will be no turbulence and no murmur will going to be produced. So this means most likely this is a cyanotic spell due to the tetralogy of the phalate. So this is murmur, second right ejection murmur at the second intercostal space which radiated to neck. It is aortic stenosis. Scenario with viral infection, then 1/6 mid-systolic murmur. So already we have told you the innocent murmur, they are soft, they are systolic, and most of the time they picked up during the viral infections. So they are, as the murmur character is just 1/6 in the systolic, most likely this is innocent murmur. Child with undetectable pulse, heart rate 300, and narrow complex tachycardia and stable. So what is the drug of choice? So this child is stable if they are saying, and the heart rate is 300 with narrow complex. That means this is supraventricular tachycardia and the drug is adenosine. One question is about syncope after swimming. So we have already discussed syncope after swimming, and there is a family history as well. Already discussed long QTS genetic position as well. And type 1 is associated with swimming. So that is why the most likely diagnosis over here would be QT, family history. Okay. A girl of 3-year age, previously fit and well. So which I discussed that whole girl. Mute your mics, everyone, please. This is a 3-year-old girl, previously fit and well, no health problem. Came to admission and you found that the blood pressure is 136. What is the best reason for that? Okay, so this is a 3-year-old girl with no health problem, previously fit. And what I told you, the most likely the cause would be over here is because the child 3-year-old may be apprehensive, maybe she, started to cry and all that. Because of that, you may have a high blood pressures. BP stereometry is used. Always remember that whenever you have a situation in which the blood pressures are high, you always go for the manual blood pressures to confirm it. Okay, so machinery like stereometers and automated, it will not going to be help out. So in that situation, the second blood pressure should be checked out by manually. You never blame anyone. Okay, this is a rule for medicine. You never blame anyone, nurses and all that. Okay, and when the child is previously well, on the first reading, never diagnose any condition. This is the first reading. Child with the following pressures and saturation on cardiac catheterization. So this is a cardiac catheterization question. Who will going to do it? Who will going to do it? Irtaza, can you try this question? Please. Irtiza? Dr. Irtiza, are you there? Dr. Aleem? Dr. Aleem, Dr. Suleiman, would you like to try this question? Dr. Sadaf, will you try? No one is here to participate. Dr. Sabi, Dr. Sobia, आवाज नहीं आ रही मुझे आप लोगों की, मेरी तरफ इशू है क्या? Yes, who will going to do it? खुद से कर लें भाई.
आवाज आ रही है मेरी?
जी जी जी, आप कीजिए डॉक्टर सभी का.
हाँ, इसमें जो है वो अयोर्टा की तो सैचुरेशन दी भी नहीं है, तो अगर हम लेफ्ट वेंट्रिकल की देखें तो वो 98% है, तो हम अज्यूम करें कि अयोर्टा भी वही होगी,
ठीक है.
तो इस हिसाब से ये ए साइनोटिक हो गया।
हम्म.
और इसमें जो है एसपीसी राइट एट्रियम राइट वेंट्रिकल की तो सेम चल रही है, पल्मोनरी आर्टरी में जो है वो स्टेप अप हो गया है, 85% हो गई है।
हम्म.
मोस्ट लाइकली ये पीडीए मतलब वेसल्स के बेसिस पे है ना, पीडीए होगा।
ठीक है. ठीक है. और इसमें क्या चीज आ रही है इसके अंदर? प्रेशर्स अगर हम देखें तो प्रेशर्स को भी देखें.
इक्वल हो गए पीए के और अयोर्टा के।
प्रेशर्स भी इक्वल हो गए ना. तो और प्रेशर्स भी इक्वल हो गए, और दूसरा हमारे पास शंटिंग जो है अभी अभी किस तरफ आ रही है? पल्मोनरी आर्टरी की डिक्रीज हो रही है ना. पल्मोनरी सॉरी पल्मोनरी आर्टरी में इंक्रीज हो रही है अभी.
लेफ्ट टू राइट जा रहा है।
लेफ्ट टू राइट है. लेफ्ट टू राइट शंटिंग अभी तो लेफ्ट टू राइट है, लेकिन अगर आप प्रेशर्स देखें आर्टरी के बहुत ज्यादा होना शुरू हो गए. ये बहुत ही जल्द किस में जाने वाली है? ये राइट टू लेफ्ट में कन्वर्ट होने वाला है. ठीक है, सही है. ये अब आइजनमेंगर की तरफ चल रहा है, तो ये लार्ज पीडीए है प्रोबेबली विथ लेफ्ट टू राइट शंटिंग है. वेरी गुड. सो दिस इज द पीडीए. Next question. This is the child of 6 years came with chest infection. So this child presented with chest infection. Mum can't hear, murmur can be heard on the right upper sternal edge. So right upper sternal edge, जहाँ पे aortic stenosis का murmur है, वहां पे सुनाया जा रहा है. The murmur is never heard before and disappear when the child is well. He has a lots of chest infections in the past. So what do you think what this murmur is? जो ऑप्शंस हैं, नीचे ऑप्शंस नहीं है. तो ये मर्मर जो कि डिसअपियर हो रहा है व्हेन द चाइल्ड इज वेल, उससे पहले कभी हर्ड नहीं किया गया. और इसमें क्या लिखा हुआ है इन्होंने? ये हर्ड हो रहा है ड्यूरिंग एट द राइट अपर स्टर्नल एज पे हो रहा है. ठीक है. तो ये है तो इनोसेंट की कैटेगरी. अब मैं आपको जो है एक चीज बता दूंगी कि हाउ यू गोइंग टू डिफरेंशिएट. हमारे पास इनोसेंट मर्मर, एक इनोसेंट मर्मर है, एक वीनस हम्प है, दैट इज आल्सो कैटेगराइज्ड एज अ इनोसेंट. सो हाउ यू गोइंग टू डिफरेंशिएट बिटवीन इट? उसकी एक डिफरेंशिएशन होती है. जो मर्मर होता है हमारे पास, उसका रिलेशनशिप होता है पोजीशन के साथ. ठीक है ना. और जो वीनस हम्प होता है उसका रिलेशनशिप इस वक्त मैं रिकॉल नहीं कर रही, बट आई टेल यू. अभी मैं आपको बुक से जो है वो चेक करके ये दोनों चीजें क्लियर कर दूंगी. तो ये आपको देखना होगा कि ये मरमर है या वीनस हम्प की बात कर रहे हैं. ठीक है. Next is the 6-month-old child who is very restless and folding his leg on his abdomen and murmur on the lower sternal border. तो ये बच्चा रेस्टलेस है, फोल्ड कर रहा है अपनी लेग्स को. ठीक है. एंड मर्मर ऑन द लोअर स्टर्नल बॉर्डर. Very restless. Normally very restless, folding his leg. This is a characteristic of the cyanotic spell. ठीक है. लेकिन cyanotic spell में you will not going to find the murmur on the lower sternal border. लोअर स्टर्नल बॉर्डर का ये जो मर्मर है और 6 months का बच्चा है, रेस्टलेस है, दिस इज अ साइनोटिक स्पेल. अब ये मर्मर यहाँ पे हम इस वक्त इसको जैसे, क्योंकि लोअर स्टर्नल बॉर्डर का मर्मर यहाँ पे आपको नहीं मिल रहा होता है. ठीक है, सो मोस्ट लाइकली द आंसर इज ओवर हियर इज अ टॉफ, क्योंकि 6 month की एज पे प्रेजेंट कर रहा है. रेस्टलेसनेस जो है वो ड्यू टू हाइपोक्सिया है. ठीक है, so we have finished this file, FOP 5. Now we'll move towards the TAS file. If you have any query, you can ask. Okay, so this TAS file is visible to everyone. Okay, next, the first question, the newborn with the stain meconium. So it's a meconium aspiration. What is the echo finding in the PPHN? PPHN we have already discussed in detail. So what is the finding?
Regurgitation.
Yes, so that is why you have a tricuspid regurgitation.
Because in PPHN is I think
The blood flow in the lung,
blood-
pulmonaries
yes.
is not moving to the lungs, okay? Because you have a hindrance, have a severe pulmonary hypertension, you have a vasculature constriction over there. So what happened when it will not move into the forward direction, it will going to be in a backward direction.
Backward
That is why we're going to find tricuspid regurgitation in this case. Now this is the right atrium IVC tricuspid valve. So coronary sinus drainage into where? So coronary sinus is basically draining all the venous blood from the heart directly into the right atrium. All know that the SVC brings the blood from the upper body, IVC brings the blood from the lower body, but the heart, the venous return of the heart will open into the coronary sinus, and then ultimately it directly opens into the right atrium. Y wave of the jugular veins represent opening of the, so you should write it down, that you should make a diagram of the this waves. This is the JVP waves, ACVY waves. So you should remember which wave is correspond with which. Okay, so this is a task you have to ratify it. So Y wave is basically tell you about the opening of the tricuspid valve. Okay, please write this down. SVT guideline, you have to read it after this lecture, and you just make this, JVP की जो waves हैं वो आपने कहीं diagram draw कर लेनी, चाहे अपने task की case की book में draw कर लें, ताकि जब आप उसको recall करेंगे during the exam तो वो waves की आपको एक एक पता हो. ठीक है, because they are asking. Ductus venosus drain at which part? तो डक्टस विनोसिस ड्रेन कहाँ पे कर रही होती है, वो कहाँ पे किसको किससे कनेक्ट कर रही होती है?
IVC.
तो क्या कर रही है, डायरेक्टली आपकी जो अम्बिलिकल वेन से जो ब्लड आ रहा है उसको शंट कर रही है इनटू द आईवीसी. ओके, okay, now the murmur they are talking about the loud continuous murmur. So if they are talking about continuous loud murmur, so mostly they are talking about the PDA. So what would be the answer? It would be associated with bounding pulse, elevated blood pressure, single second heart sounds, or fixed splitting second heart sounds. So what could be the option in this scenario? The most likely
Bounding pulse.
with bounding pulses. So bounding, yes, PDA. PDA is associated with bounding pulses. PD, and what other condition I told you about the bounding pulses? It is aortic regurgitation. It is something anemia that all can cause some, or thyrotoxicosis. These all are the conditions which are associated with the bounding pulses. Systolic murmur at left upper sternal edge in ECG shows right bundle branch block. So what is the characteristic? This is a murmur at the left and it is associated with bundle branch block. So in which condition we discussed about bundle branch block? If you can recall, it is the ASD. And which type of ASD? It's associated with the right bundle branch block. It is the secondum. Okay. So it's a secondum ASD and it is associated with fixed split second heart sounds. Okay. Systolic murmur radiating to the back with left ventricular hypertrophy. So now they are talking about a murmur which is radiating to the back and it is associated with left ventricular hypertrophy. So most likely what could be the answer over here?
Elevated BP.
Elevated BP. Very good. It is a coarctation of aorta. Okay. In back murmur, back पे murmur आपका PS का भी murmur radiate करता है, but pulmonary stenosis would going to be associated with right ventricular hypertrophy. Okay. So this is not the PS, this is coarctation of aorta because it is associated with left ventricular hypertrophy. Which causes left to right shunt? Please be careful reading the scenario. Which causes left to right shunt? आपकी shunting की direction change हो गई है. Initially in the fetal life, the shunt is right to left. So now the shunt become left to right through the foramen ovale. So at the level of the foramen ovale, the direction has changed after the cord clamping. So cord clamping के बाद ये जो direction change हो रही है, ये किस factor की वजह से change हो रही है? The factors are given below. Yes.
Increase systemic
SVR
resistance.
increase.
Increase systemic resistance.
Systemic resistance का जो है ना
Sorry.
आप एट्रियम पे कनेक्शन नहीं, ये देखें.
Increase right.
ठीक है, एट्रियम के लेवल पे अगर आपका शंट रिवर्स हो रहा है तो वो क्या फैक्टर है कि एट्रियम का ब्लड फ्लो इंक्रीज हुआ था. आपको याद है जो हमने डिस्कस किया था कि जैसे ही आपने फीटल लाइफ से जब ट्रांजिशन हुआ तो आपका राइट एट्रियम का ब्लड कम हुआ. Why it decreased? Because you cut it down the placenta. आपने एक placenta को remove किया, ब्लड का फ्लो वहां कम हो, लेकिन लेफ्ट साइड का बढ़ा क्यों था ब्लड का फ्लो? Because of pulmonary vasodilation. जब पल्मोनरी में ब्लड एंटर हुआ तो वापस भी आया लेफ्ट एट्रियम में. ठीक है, आपने जब पल्मोनरी को डायलेट हुआ वहां से ब्लड फ्लो लंग्स में गया, लंग से रिटर्न होके लेफ्ट एट्रियम में आया. तो एक साइड का ब्लड कम हो रहा है, राइट साइड का कम हो रहा है और लेफ्ट साइड का बढ़ रहा है. दैट वुड कॉज द ये शंट की जो डायरेक्शन चेंज हुई है वो इस वजह से. ठीक है, so the answer would be over here is pulmonary vasodilation. Systemic resistance would not cause shunting reversal at the atrium level. Increased right atrial pressure is wrong. It causes decrease because placenta is removed. Placental circulation interruption will cause decreased right atrial pressure. Okay, तो वो आपकी decrease करेगी. So left to right basically आपका flow increase हुआ है left side का because of pulmonary vasodilation. Again, this is cardiac catheterization question. Then who will going to attempt this question? Who will going to attempt?
Okay, me.
Okay.
Okay. Aorta is first 84, so it's a cyanotic heart disease, and right atria 74, right ventricle 74, PA 74, all normal. Then left atria 84, and left atria 93, and left ventricle 84. So ये sudden left ventricle की side पे कम हुआ है इसका pressure. तो sorry, and PA is 74 also. So left ventricle में ये 93 से 84 हुआ है, means something is wrong in left ventricle, and the PA is also 74. Then अगर हम pressure की तरफ जाते हैं तो Right atria 7, right ventricle 88, means again right ventricle में pressure बढ़ रहा है and PA में pressure जो है वो decrease हो रहा है. Means VSG and also VSG के साथ ये cyanotic heart disease है, तो ये PA के अंदर pressure भी कम हो रहा था और ये 18 हुआ है, तो ये pulmonary stenosis हम इसको कह सकते हैं. Pulmonary stenosis and VSG means stop.
Very good. Okay. So this is VSD with pulmonary stenosis. That is why is stop. And what would you going to find out in VSD with Eisenmenger? Sadaf, what would be the thing with VSD with Eisenmenger?
इसमें pulmonary stenosis नहीं होता, just VSD हमें मिलेगा और then वो large VSD होगा और उसमें left to right shunt हो जाएगा आगे जाके.
उसमें जो इम्पोर्टेंट चीज होगी वो ये होगी कि वेंट्रिकल्स के प्रेशर भी हाई होंगे और पल्मोनरी आर्टरी के प्रेशर भी हाई होंगे. ठीक है, यहाँ डिफरेंस नहीं होगा. यहाँ पल्मोनरी आर्टरी भी 8800 के करीब पहुंची हुई होगी. दैट मीन्स ये आइजनमेंगर हो चुका है. ठीक है, नेक्स्ट. Neonate 39-week gestation delivered to a mother 28 years old come back after discharge. So अब जो भी सिनेरियोज हैं वो अब वो बच्चा जो है वो डिस्चार्ज के बाद आया है, न्यूनेट है. ठीक है, सब आपने न्यूनेट को माइंड में रखते हुए सोचना है. तीनों के तीनों बच्चा जो है वो 24 आवर्स के बाद आ गए. तीनों के तीनों टर्म है, माइंड में टर्म है, सेकेंड डे पे प्रेजेंटेशन है. ठीक है, so after 24 hours you can see the first child presented with respiratory rate 40, saturation is 60. So if it's the saturation is 60, 68, third में भी 80. so mostly अब saturation से समझ आ रहा है कि ये साइनोटिक वाले 60 आ रहे हैं, बहुत ज्यादा साइनोसिस के साथ आ रहे हैं. ठीक है, and if you say x-ray shows mild सा plethora, तो blackout lungs नहीं है बल्कि mild सा plethora है. Axis is 120. So what do you mean by axis? If it is axis is 120, what do you think? The normal axis की क्या range बताई गई थी आपको? -30 से up till 90. So if it is exceeding the 90, then what do you think? The axis is 120 means that the axis is on the right side. Okay? Right side. So if it is in minus, doctor, then only you can say left. Okay, so -30 से ऊपर, like for example, if it is going -20, -10, -40, -50, -60, then you can say left. So this is right axis deviation with no murmur. Brachiofemoral is normal. So there is femoral is normal. So if you can appreciate the femoral, that means systemic related things should be out. Femoral पे blood आ रहा है. Liver is 1 cm, no ventricular hypertrophy, no parasternal heave. So at this one day पे कोई hypertrophy नहीं है, कोई parasternal नहीं है. So the important thing, right axis means right side prominent है, mild सा plethora है और saturation 60 है, present हो गया है second day पे. So what do you think? What could be the diagnosis from above? क्या लग रहा है? फर्स्ट डे पे साइनोसिस आ रहा है. TGA, transposition of the great arteries. Very good. So transposition of great artery में you all know that कि aorta is originating from the right side. Okay, and we all know that the right side is mostly in the fetal life. If talk about when the newborn is born, the right side is predominant. Okay, and plethoric lungs means the blood flow is going to the lungs. There is no obstruction. There is no pulmonary stenosis. That is why you have plethoric lungs. Plethora means flow is in the lungs. So that is why you prefer to go over here is transposition of the great arteries. Okay. Next question. Next question is, just a second. एक second, I'm just opening. Okay, so what is the next question? So we have discussed, this is most likely, this is the At this time, this is most likely PJ. Now the second question. After 24 hours, again, this is after 24 hours, respiratory rate 40, saturation is 68, but lungs are oligemic and axis is 33. Axis is 33. TK means, what do you mean by axis is 33? Means that
Left
axis is
axis
normal. TK,
normal.
no, if it is minus, doctor, if it is in minus, then you can say it's left axis, okay? The axis is okay. Ejection systolic murmur. Now you're getting murmur, ejection systolic murmur, along with the right ventricular hypertrophy with normal brachiofemoral. So if it's a brachiofemoral is normal, that means no systemic related, no HLH, no something like that. So you think about in the
Top.
sign line with oligemic means flow is not in the lungs with the murmur. So most likely the diagnosis over here is
Top.
cough. So among them, अगर आप उसमें बात करो, TAPVR is associated with very, very congested lung. It's not the mild plethoric, वो पूरे के पूरे snowman appearance थी. याद है आपको TAPVR? I've shown you the X-ray, okay? So that is why it is more likely TOF because the word is oligemic. Now on the second day, to see the sometime the very, if you have a very critical pulmonary stenosis is there, you may present very early as well, but it is less likely, but it can occur, okay? On second day, in the next baby, you can say the respiratory rate is 70, saturation is 80. It's not very cyanotic, and the lungs are also plethoric. And the axis is 140. So if the axis is 140, again, it is going into right-sided problems, okay? It is right axis deviation with all pulses low. So the word over here is all pulses low with no murmur. So what do you think? What is the problem over here?
Hypoplastic left heart.
वेरी गुड. अलीम आप क्या कह रहे थे?
Total anomalous pulmonary venous rate.
Total anomalous pulmonary venous return. See, if pulses are low means systemic related problem. It is not related to the, and you can see the cyanosis is okay 80% because definitely if you do not have a blood flow, you have a, mottling is there, the periphery will going to be cool. Maybe you will not able to pick up the correct saturation. But if pulses is not there, you should think about systemic related problem rather than these, veins and right-sided problem. Okay. So that is why all pulses word is more going towards HLH, hypoplastic left heart syndrome. Now child again with potassium 7.1 ECG shows tall T wave, widened QRS complex. What more may be seen in the ECG? So now you have to write, you should know the ECG findings, especially related to the hypokalemia, hyperkalemia, hypocalcemia and hypercalcemia. So you should write the third point. ये ECGs भी आपने उसकी findings को अपने पास कहीं लिख लेनी है, ठीक है? क्योंकि आप भूल जाएंगे. So over here the answer would be with, if you have a potassium is high, you have tall T waves. If there is a widening of the QRS, there is a prolonged PR. So everything will be going to be wide. So the answer would be over here is the prolonged PR interval. Now starting of the vent. Now they are talking about the starting point. The starting of the ventricular repolarization. Start of the ventricular repolarization कौन आपको बता रहा होता है?
T wave. T wave.
Waves is basically representing you the ventricular repolarization. Okay, so ventricular repolarization, if it's entering, it is associated with T wave. QT calculation, it is what is क्या है इसमें QT interval है divided by square root of
RR interval.
yes, it's a one option. Child with QT, long QT, which antibiotic to be avoided? So the question is avoided. So what I told you,
Erythromycin.
very good. You should know about macrolides are associated with the long acquired causes. May you should remove macrolides, clarithromycin. Baby of diabetic mother, weight 4.2 kg, Midwife say he is cyanosed, okay, found to be jittery. Respiratory rate is okay, 40. Heart rate is also okay. And the child is also normal feeding. तो अब यहाँ पे डायबिटिक मदर है, वेट बच्चे का 4.2 है, मिडवाइफ को वो साइनोज लग रही है और जिटरी भी. आपने एबीजीज रन करी, एबीजीज में पीएच इज 7.4, that is normal. PCO2 is 4.6, that is again normal. The normal range in KPA, in UK, you will going to find for ABG's unit should be in KPA. So the normal range for PCO2 is 4 to 6 kPa. So again, this is in the normal range. PO2 is 11 kPa, more than 10. So more than 10 is the normal value. Again, PO2 is normal. Sorry. After oxygen supplementation, what you're going to find out that PO2 will going to be increased more. So before oxygen, it was also normal. It was 11. After that, it further increases. So what is the pathophysiology of the cyanosis over here? So what is the pathophysiology? Do you think why this child appears cyanotic? Why? एक चीज मैंने बताई थी, साइनोसिस को अपेयर होने में the more the child will be polycythemic, the more he will appear more cyanotic early. सही है ना? क्या आपको एग्जांपल बताई गई थी कि जिसका 20 का हीमोग्लोबिन था, ठीक है ना, हमने क्या पढ़ा था कि उसका 5% हीमोग्लोबिन जो है जब डीऑक्सीजनेटेड होगा तो वो सैचुरेशन अपेयर करेगा. तो वो बच्चा जब 70% ही उसकी जो है वो सैचुरेशन थी, यानी कि 20 में से 5 आपने कर लिए, यानी कि 15 का हीमोग्लोबिन पे वो अपेयर हो गया था साइनोटिक. जितना आप प्लेथोरिक होते जाएंगे उतना अर्ली आप साइनोटिक अपेयर हो जाएंगे. 80-85 के ऊपर भी आप बहुत ज्यादा साइनोटिक लगेंगे. इवन दो इसकी सैचुरेशन ऑक्सीजन सही है कंटेंट, ठीक है ना, लेकिन ये बहुत ज्यादा प्लेथोरिक हुआ है बच्चा. क्यों प्लेथोरिक हुआ है ये बच्चा? क्योंकि ये डायबिटिक मदर थी, इसका यूट्राइन इरिथ्रोपोइसिस ज्यादा था, हाइपोक्सिया की वजह से, डायबिटीज होने की वजह से, वहां पे प्लेसेंटल फ्लो अच्छा नहीं होता, जिसकी वजह से बच्चा जो है वो पॉलीसाइथेमिक है और वो अपीयर हो रहा है एज अ साइनोसिस. इवन तो इसकी सेचुरेशन 92 93 होगी या 94 भी होगी क्योंकि इसकी PO2 बिल्कुल नॉर्मल है, लेकिन उसका हीमोग्लोबिन 5 ग्राम उसमें हो गया होगा डीऑक्सीजनेटेड, दैट इज वाई वो अपीयर हो रहा है. ठीक है, तो जितना पॉलीसाइथेमिक होगा वो उतनी कम, उतनी ही ज्यादा सेचुरेशन पे, सेचुरेशन सही चल रही होगी उसमें वो जल्दी अपीयर हो जाएगा साइनोसिस. जितना बच्चा एनीमिक होगा, जैसे हमने एग्जांपल ली थी कि वो जिसका 10 का हीमोग्लोबिन था उसकी सेचुरेशन जब 50% पे गिरी थी तब जाके उसका साइनोसिस अपीयर हुआ था. ठीक है ना? I think you can recall that example, okay? So the example over here is polycythemia. Why polycythemia? Because of increased intrauterine erythropoiesis. Factors that promote the immediate closure of ductus arteriosus. Now they are talking about the closure, an immediate closure. Which factors are responsible? Yes.
Increase flow towards the lung.
Very good. So if you have high oxygen, it will cause immediate closure. Other factors are responsible with the opening of the ductus arteriosus. Tetralogy of Fallot. What is the cause of the cyanosis? So why cyanosis occur in the
आंसर 4 होगा ना, 4 होगा, increase blood flow.
increase blood flow because prostaglandin E2 will going to keep open. Okay, हम देते हैं ये, increased blood flow. Next, tetralogy of the Fallot. What is the cause of the cyanosis in the TOF patient? Why cyanosis occur?
5.
Yes.
Right ventricular outflow tract obstruction.
Right ventricular outflow.
Obstruction. What happened in cyanotic spell? The obstruction increases. That is why the child become more cyanotic. In the TOF, we have already large VSD. So there is no significant shunting is going on. Because large VSD में the pressures you can see the same in both the chambers. So it is not the right to left shunting that causes cyanosis in this picture. It is the decreased pulmonary flow to the pulmonaries that causes cyanosis. Okay, now defect. Okay, now these are the different options. The scenario is below. Now you will going to answer me, okay? 10-day-old newborn, this 10-day-old newborn, the saturation is 88 in the air. That means this is a cyanotic, 88 पे present हुआ है with the plethoric lungs. We have already discussed the blood is going into the lungs. Murmur is just the 1/6 of systolic. So murmur is insignificant. Antenatal echo is normal. The word over here is the antenatal echo is normal. So if antenatally, they are not talking about the postnatal, antenatal echo is normal, plethoric lungs, saturation is 88%. So what do you think? What could be the cause? The TGA will going to be pick up on the echo because the larger veins problem is there. You can easily pick up on the antenatal echo. So what other finding which associated with plethoric lungs with decreased saturation? Yes. पहले डायग्नोसिस बता दें फिर अंदर की पैथोफिजियोलॉजी बता दीजिएगा. What do you think? What could be the cause? This is the scenario, Aleem. This is the TAPVR. Okay. Total anomalous pulmonary venous. You have a plethoric lungs. Okay. They do not say mild or something like that. Okay. But antenatal.
पिक हो जाएगा एंटीनेटली या नहीं होगा?
क्योंकि उसमें कनेक्शंस के इशू होते हैं ना बिल्कुल ऊपर के जो आपकी पल्मोनरी वेन्स का जो कनेक्शन जो राइट एट्रियम में खुल रहा है या एसवीसी में खुल रहा है या आईवीसी में वो कनेक्शंस जो होते हैं ना वो इतना एंटीनेटल इको उतना ज्यादा पिक नहीं कर सकता. एंटीनेटल इको ज्यादा चैम्बर रिलेटेड लार्ज वेसल रिलेटेड चीजों को पिक कर लेगा, हाइपोप्लास्टिक को पिक कर लेगा, ये चीजों को पिक करेगा, वाल्व बंद हो रही है, नीचे हाइपोप्लेजिया हो रहा है, ये सब चीजें पिक कर लेगा. ठीक है. So that is why the answer over here is that what is that? The failure of the pulmonary veins. क्योंकि pulmonary veins already open होती हैं, फिर इसका opening कहाँ पे हो रही है? It's difficult. Failure of the veins to drain in the left side and rather it drains in the right side. This is the pathophysiology of the TAPVR. It is associated with plethoric lungs, not the mild plethora. It's completely snowman appearance, okay? So mild, it's a plethoric cyanotic heart disease. And because the drain connection is a problem, so you do not get a specific murmur, okay? Next, the 1 week old boy, poor feeding, this is a 1 week boy, poor feeding, cyanosis, saturation is 82 with oligemic lung fields. Now they're telling you that there is no flow to the lung. Systolic murmur on the left upper sternal edge, right ventricular hypertrophy, right axis deviation. So what is the diagnosis over here? This is a simple, what's the diagnosis?
Off.
TOF. So what is the option from above? It's
C.
most C. Okay, disalignment wala, the C. 6-year-old hypertension, this is hypertension, 6-year-old hypertension, headache, systolic murmur that radiated to the back and associated with LVH. So what is this?
FOP tissue.
But what would be the answer? B or G? B or G? Yes. It is postductal. It is postductal. It is narrowing in the descending aorta. Okay. Do not be confused. Your duct open at the descending aorta. So it's a narrowing in the descending aorta. It's a postductal. Child with the syncopal attack, cardiac catheter reserve. So again, this is a cardiac catheterization is there. So now who will going to do this question? Yes, who will going to try? Dr. Suleiman, last time you didn't do any question. Will you try now? Are you there? Dr. Suleiman. Yes, please try. You are not audible.
बोल के दे दे बाबा से बात करने मुझे अच्छा नहीं लग रहा है बदतमीजी करके
आवाज नहीं आ रही।
Yes, mute था actually. Dr. Salman, are you participating or not? आपका माइक ओपन है पर हमें आवाज नहीं आ रही. Anyone
मैं कर
else?
लूं?
अच्छा,
मैं कर लूं ये?
जी 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 कर लीजिए.
सबसे पहले femoral artery is 98%, तो इसको हम समझेंगे कि ये acyanotic heart disease है। उसके बाद saturation में SVC 79, RA 78 और RV is 78, ठीक है, and PA is 80। तो एक तरह से saturation सारी एक जैसी ही है, और इसमें LA की saturation नहीं दी हुई, बट LV की 97% है, जो कि सही है। बाकी प्रेशर्स देखते हैं, तो SVC और RA में 3 है, और RB में भी 40/3 है, पल्मोनरी में भी 40/10 है, लेकिन जो LV है उसमें 130/60 है, ठीक है। तो इसका ये मतलब है कि ऑब्स्ट्रक्शन जो है वो आफ्टर LV है, तो यानी एओर्टा में ऑब्स्ट्रक्शन है, तो इसको हम AS कह सकते हैं।
यस, वेरी गुड. अगर आप आर्टरी का प्रेशर देखिए वो कम हो रहा है. देयर इज अ डिफरेंस ऑफ अराउंड 50 millimeter. So this difference is significant. So that is why this is more likely aortic stenosis. Next question, tracheoesophageal fistula develops at what stage? So ये question basically आपका respiratory का है, and I'm going to explain tomorrow the embryology of the respiratory system. So ये tracheoesophageal fistula occur at very early stage, that is embryonic stage of the lung development. So we're going to discuss tomorrow, so don't worry about that question. What is the cause of the transposition of the arteries in the embryo? Transposition of the great arteries क्यों हो रहा है? ट्रांसपोजिशन आपका क्यों हो रहा है? तो डेफिनेटली अगर आप ग्रेट आर्टरीज जो थी आपके सबसे ट्यूब जो बन रही थी, ट्यूब का ही जो है इसका कोई कनेक्शन न्यूरल से नहीं था. यू हैव ऑल सीन द एम्ब्रियोलॉजी ऑफ द कार्डियोलॉजी. So it's a concern. It is related to the migration of the endocardial cushions. Okay, a case of diagnosis TAPVR, total anomalous pulmonary venous return या फिर total anomalous pulmonary venous drainage. The thing is same. X-ray was done. What's the cause of this finding? So why the X-ray is so flooded or plethoric? So they are asking about the cause of it. So what is the cause in this scenario? It is the obstruction of the pulmonary veins. So pulmonary veins का obstruction कहाँ most common है? Pulmonary veins normally आपकी drain होती है into left atrium. But if they are not draining into the left side, and when they are opening into the right, they may have a choice. They either enter into the superior vena cava, they enter into the you can say the right atrium, or they may take a very long course and can open into the inferior vena cava, which we call as infracardiac TAPVR, infracardiac. So infracardiac TAPVR, which opens into the inferior vena cava, as it takes a very long course, they are associated with obstruction in it. And whenever there is an obstruction and it is an infracardiac TAPVR, it is an emergency. You have to manage that child in an emergency situation. If TAPVR is associated with obstruction, and in which state the obstruction is common, If it is infracardiac, that means if they are opening into the inferior vena cava. Okay. Term baby with spontaneous onset of labor. This is a term baby present with spontaneous onset of labor after transaction to extrauterine life. Now they are entering into the extrauterine. What indicate the normal cardiac vascular anatomy? So क्या changes होती हैं, क्या इसका normal? कैटाकोलामीन हेल्प इन द फ्लूइड क्लियरेंस? नो. फ्लूइड क्लियरेंस कैसे हो रही होती है? जब आप ब्रेथ लेते हैं, एयर आती है, तब आपकी फ्लूइड क्लियरेंस स्टार्ट होती है. रिमूवल ऑफ द प्लासेंटा विल इंक्रीज लेफ्ट एट्रियम? नो. रिमूवल ऑफ द प्लासेंटा विल कॉज डिक्रीज इन द राइट एट्रियम प्रेशर. प्लेसेंटा बाय ऑक्सीजनेटेड ब्लड बाय अम्बिलिकल आर्टरी. प्लेसेंटा में जो ऑक्सीजनेटेड ब्लड है वो आपका अम्बिलिकल वेन से आ रहा होता है. ठीक है. वेरी लो फीटल पल्मोनरी वैस्कुलर रेजिस्टेंस. तो आपकी जो पल्मोनरी की जो रेजिस्टेंस है फीटल लाइफ में वो वेरी लो नहीं होती, बल्कि क्या होती है, वेरी वेरी हाई होती है. ठीक है. अच्छा, अब यहाँ पे जो ऑप्शन जो ये लग रहा है कि प्लेसेंटा का रिमूवल होने से आपके राइट साइड के प्रेशर तो कम हो जाते हैं, लेकिन आपका लेफ्ट साइड के जो प्रेशर इंक्रीज होते हैं उसका मैंने रीजन आपको बताया था, वो पल्मोनरी वेजो डायलेशन है. ठीक है. तो यहाँ पे जो ऑप्शन जो वेरी क्लोज लग रहा है वो B2 लग रहा है, लेकिन वो भी एकदम करेक्ट नहीं है. अगर आप प्लेसेंटा को रिमूव करते हैं तो आप बेसिकली एट्रियम, राइट एट्रियम के फ्लो को कम करते हैं, राइट एट्रियम के प्रेशर को कम करते हैं. ये डायरेक्ट काम है प्लेसेंटा का. ठीक है ना. बाकी सारा चूंकि ये रिकॉल है तो इसमें हम बाकी ऑप्शंस को जो है ना वो कह नहीं सकते. ठीक है. बाकी हम एक्सक्लूड कर सकते हैं कि ये हमने एक्सक्लूड कर दिया है कि फीटल लाइफ के अंदर हाई पल्मोनरी रेजिस्टेंस होता है, प्लेसेंटा में ऑक्सीजनेटेड ब्लड अम्बिलिकल वेन के अंदर होता है. कैटाकोलामीन्स हेल्प इन द फ्लूइड क्लियरेंस फ्रॉम द लंग्स. अब ये कैटाकोलामीन की वजह से फ्लूइड क्लियरेंस नहीं है, इट इज ड्यू टू द चाइल्ड टेक्स ब्रेथ, तो फिर आपका रिप्लेस हो जाता है एयर से फ्लूइड. Which one is the duct dependent system? Now they are talking about duct dependent or systemic flow problem है. तो duct dependent systemic flow lesion कौन सा है लीम इसके अंदर?
critical aortic stenosis.
It is critical aortic stenosis. Now they are talking about starting of the ventricle relaxation. अब ये ventricular repolarization की बात नहीं हो रही, यहाँ पे वर्ड जो है ना ventricle contraction, ventricle relaxation की बात हो रही है. ठीक है. So ventricle contraction QRS complex करवाता है. ठीक है. QRS complex से ventricular relaxation होती है. Relaxation कॉन्ट्रैक्शन जो है वो आपकी QRS कॉम्प्लेक्स होती. अब दे आर टॉकिंग स्पेसिफिकली अबाउट रिलैक्सेशन, नॉट द रिपोलराइजेशन. तो स्टार्टिंग पॉइंट को हम क्या कहते हैं, जहां से ये स्टार्ट होता है वो J पॉइंट होता है. J पॉइंट कौन सा पॉइंट था? मैंने आपको दिखाया था कि जब आपने QRS जब आपका QRS कॉम्प्लेक्स खत्म होता है, ST सेगमेंट स्टार्ट होता है. ठीक है. लाइक लेट मी ड्रॉ टू मेक इट क्लियर. ये आपका ये आपका QRS कॉम्प्लेक्स खत्म होके ये पॉइंट जो है, ये वाला पॉइंट जहाँ पे आपका ST सेगमेंट स्टार्ट हो रहा है, दिस इज योर J पॉइंट. ठीक है. सो व्हाट इज अ J पॉइंट? J पॉइंट बेसिकली इट्स अ स्टार्टिंग पॉइंट ऑफ द वेंट्रिकुलर रिलैक्सेशन. ठीक है. ये वेंट्रिकुलर रिलैक्सेशन का स्टार्टिंग पॉइंट है. चेंजेस एट द बर्थ, चेंजेस आफ्टर द बर्थ. चेंजेस आफ्टर द बर्थ क्या होती है? डिक्रीज होता है पल्मोनरी ब्लड फ्लो? नो. पल्मोनरी ब्लड फ्लो आफ्टर बर्थ इंक्रीज होता है. इंक्रीज पल्मोनरी रेजिस्टेंस? नो. पल्मोनरी रेजिस्टेंस डिक्रीज होती है. इंक्रीज पेरिफेरल वैस्कुलर रेजिस्टेंस? यस. सिस्टमिक रेजिस्टेंस या पेरिफेरल वैस्कुलर रेजिस्टेंस इज इंक्रीज आफ्टर द बर्थ. So the option would be C in this case. So we have finished our this part as well. Okay. तो ये हमारे क्वेश्चंस भी खत्म हो गए. इफ यू हैव एनी क्वेरी, अच्छा कुछ प्रैक्टिस के जिसको अगर प्रॉब्लम हो रही है कार्डियक कैथेटराइजेशन के, तो एक दो प्रैक्टिसिंग मटेरियल मेरे पास है. आई विल सेंड यू दैट एज वेल फॉर योर प्रैक्टिस. So inshallah we will going to start respiratory part tomorrow. Okay. So if you have any questions you can ask, then we will going to end this session. कुछ और पढ़ाई करते हुए कुछ और प्रॉब्लम हुआ, कुछ और डिस्कस करना हो तो यू कैन आस्क एज वेल, अभी भी पूछ सकते हैं, बिकॉज वी हैव अ टाइम। ऐसा नहीं कि हम डिस्कस नहीं कर सकते। कोई चीज जो डॉक्सोबिया आप लोगों ने पढ़ी हो, आप लोगों को नहीं समझ आई हो, एसओपी से, इलस्ट्रेटेड से, क्लिनिकल केसेस से, ईसीजी से, कुछ भी, किसी के कोई क्वेश्चन रिगार्डिंग, हम इतने दिनों बाद मिल रहे हैं, या तो सबको सब समझ आ जाता है या कुछ नहीं समझ आता। ये दो ही कैटेगरी होती है जब कोई कुछ नहीं बोलता। एनी क्वेश्चंस? डॉक्टर अलीम, आप लोगों की स्टडी हो गई थी, डॉक्सोबिया सब कंप्लीट हो गया, कार्डियोलॉजी पूरा हो गया कंप्लीट?
नई स्टडी रहती है।
देखिए आप लोग कर लें, टाइमली कर लेंगे ना इंशाल्लाह, आप लोग एंजॉय भी करेंगे। और टाइमली जब चीजें आप पढ़ रहे होते हैं, उसको जब आप बुक से खोलते हैं, उसकी सेकंड रीड होती है, फिर आप क्वेश्चन सॉल्व करते हैं, तो आपकी चीजें रिटेन होना शुरू हो जाती है। फिर एंड में बहुत सारी चीजें होती हैं करने के लिए, फिर और भी क्वेश्चन पेपर्स एंड में आपके जो रिसेंट होंगे 2023, 24, वो पेपर्स हैं, चीजें कॉम्प्लिकेटेड हो जाती हैं आखिर में, फिर है भी स्टैटिस्टिक्स, ये सारी चीजें मुश्किल हैं। तो प्लीज आप लोग सब साथ साथ अपना रीड करते जाएं, ठीक है? और जो ना समझ आए फिर उसको रिकॉल के क्लासेस में रख लिया करें कि भाई ये टॉपिक समझ नहीं आ रहा था, इसको डिस्कस कर लें। एक चीज है ऑक्सीजन डिसोसिएशन कर्व, जो किसी ने मुझसे पूछा नहीं, जो आप लोगों की उस बुक में था, टास्क की बुक में, वो मैं रिस्पिरेटरी में कवर करवा दूंगी, वो मैंने नहीं कवर करवाया हुआ था, वो रिस्पिरेटरी पार्ट में कवर हो जाएगा, ठीक है? ओके, we just finished over here, and thank you so much. If you have any questions, if you want to discuss anything, you can directly message on the group. Okay, do not direct message me. सबका फायदा होगा, just put the message on the group. Okay, thank you so much everyone. Allah Hafiz.
Allah Hafiz.